Welcome everybody to 2021, a year in review. I am Dr. Len Calabrese, coming at you from the Cleveland Clinic in Cleveland, Ohio. And I'm here with two colleagues, good friends and noted experts in the field to work our way through
recording in
highlights
progress
in rheumatology and immunology from the past year. So joining me today, I'll say a little bit more about them as their turn comes up, is Kevin Winthrop, infectious diseases at Oregon Health Science Center, and Xavier Mariette, head of rheumatology department, Bicêtre Hospital, Paris Sud University. And I know they're well known to you, and I'll say a little bit more. These are our disclosures, and they are logged into this, and you can look at them later. And so this is how this is going to go. This is live, and it'll be archived. You guys on the other side will be on mute for the duration of the meeting, but you can submit speaker questions through the question and answer function. And if you have any issues at all, use the chat box to shout out with us. So we have like several segments here, and each speaker is going to go through their presentation, and then we're going to kind of roundtable it and weave the chat into this. I think it's going to be a lot of fun because I already have a lot of questions from some of these presentations that are coming down the line. So we're going to start, and I'm going to reintroduce Kevin a little bit more. Dr. Winthrop is the most famous infectious disease practitioner in rheumatology. It's quite a position to be in, and everybody turns to him to help interpret the intersection of autoimmune diseases, targeted therapies, and infectious diseases. And who would have thought 2 years ago we'd be where we're at, where that's all we talk about. Kevin, I really don't want to embellish this anymore. You've been thinking about writing about zoster for a long time. Give us a scoop.
Sure. Thanks, Len. It's a pleasure to be here with you and Xavier. Hi, Xavier. Hope you're doing well over there. Yeah, it's fun getting together and just, thinking about some of the best publications of 2021, trying not to just talk about COVID, so although we'll let Xavier talk quite a bit about it today. But, herpes zoster and JAK inhibitors is, I guess, an old story, but there's still new things that we're learning every year. This study that I was going to highlight actually goes beyond JAK inhibitors. It was from the Rabbit Registry in Germany. You're all well familiar with their work. They do excellent work. It's a large registry, large cohort of patients starting biologic DMARDs or targeted synthetic DMARDs, as well as patients on conventional synthetic DMARDs to then add something to that therapy. So they took this cohort that's been running prospectively, since 2007, people have been enrolled prospectively, and they looked at herpes zoster in relation to their biologic DMARD start or their JAK inhibitor start, or they're using the reference of the patients starting conventional synthetic DMARDs. And they, of course, calculated incidence rates. And of course, these groups were fairly different. I guess the one idea is they're all stepping up therapy. So it means they're all probably not well controlled from a disease activity standpoint, from an RA standpoint, but they did use inverse probability weighting to adjust for differential characteristics between those exposure groups. And then they identified herpes zoster events or shingles events in each of these groups. They calculated event rates. They also calculated incidence rates. I favor the incidence rates. Those are where you actually censor someone at the time of their event so that they're no longer held at risk for it. An event rate, which is here on the slide, is more that you can have multiple events in the same study time period. The benefit of that is you can look at the small number of people who actually have recurrent events and see if there's something different about them. It's a little odd to have recurrent zoster, but that is something we see particularly in the context of JAK inhibition from a number of studies. So what did they find? Let's see what they found here. A little surprising, but not really surprising. And it's consistent with other studies from Europe that have been published before, a bit different than what we found in multiple North American studies. This is in regards to TNF blockers. There's about 9 or 10 studies now that have, in population-based fashion, looked at the issue of whether TNF blockers increase the risk of zoster. They found an adjusted hazard ratio here for the monoclonal TNF blockers of 1.63, which was a bit higher than what they found for etanercept in the second row there. The p-value for the monoclonals reached significance, and this was again compared to conventional synthetic DMARDs. You can also see a number of other compounds there reaching statistical significance, B-cell depletion therapy, and then, of course, JAK inhibitors. And you can see a very high adjusted hazard ratio, about 2 to 3-fold higher for the JAK inhibitors, which is consistent with pretty much all the studies that have been done, whether from clinical trial data or real-world data, looking at the relative risk of JAK inhibitors combined relative to biologics combined. What I also want to point out is the hazard ratios for each of these types of biologic DMARDs, despite some of them not reaching statistical significance, like IL-6 inhibitors. I mean, the p-value was 0.0578. You see a hazard ratio of 1.44. Even for etanercept, even for abatacept, you see lowish p-values, but you see hazard ratios of pretty similar, it's of similar magnitude, and you see confidence intervals all overlapping each other. I would say this is consistent with what we've seen in our studies personally, but also others who have come from North America, where biologics in general seem to carry pretty similar risks, and it is of 2 to 3-fold lower magnitude than JAK inhibitors. So while there may be some differences here between the individual biologics, they don't appear very great to me. But it did raise the question of whether monoclonals, TNF blockers are something special. The last thing I'll mention is not on the table here is the influence of steroids. The authors did a number of sensitivity analyses, which were very well done. They also looked at steroids both low and high dose. And of course, they saw a dose-dependent effect in risk according to steroids. And, in their model of risk factors across these therapies, age, of course, was very important, but glucocorticoids at a dose greater than 10 milligrams a day was by far the strongest risk factor for zoster in this analysis, and even stronger than JAK inhibitors with an adjusted hazard ratio of 4 or 4.5, if I remember right. So take-home messages, probably most patients who are stepping on therapies, no matter what therapy, they're probably at slightly higher risk. The same story with JAK inhibitors in higher dose glucocorticoids being our strongest risk factors. And then probably there is some slight difference between some of the biologics, but by and large, most of them seem to raise risk to a similar degree. Len, that's my summary.
Well, it's a great summary. And, I think this has added significantly to this, the extant literature on this. I would say two things. One, I think it's very timely, because at least in the United States, the CDC, ACIP has just in the last couple of months approved Shingrix for immunocompromised patients under the age of 50. So that this lends weight to that, that I think all of these patients, this should be at least considered in. Xavier, are you guys immunizing younger patients with Shingrix?
No, unfortunately, we don't have this vaccine yet in our country. It will be very soon, but until now, we just have Zostavax. And regarding the fact it is a live vaccine, not so efficient that the Shingrix, so we did not begin to vaccinate our patients. But as soon as it will be available in the country, I think we'll do.
I'd like to ask both of you guys, if I look at that data and just kind of think about it, like as we like to say, the dog that's not barking there, abatacept is as low as any of them. And if I had to pick a drug, and knowing that what abatacept and belatacept do with at least have the potential in maintaining control over latent viruses, belatacept and CMV and et cetera. I'm surprised that there's not a bigger signal with that pathway. Thoughts?
Oh, I guess my thought would be, I agree. I mean, I think, if you looked at some of the other sensitivity analyses in that paper, there's another model where they looked at the risk of herpes zoster for people who had started that exposure group, but had some interruptions during the course of therapy. And anyway, in that model, abatacept, the p-value is 0.05, the hazard ratio is 1.6. So, I mean, I think it looks pretty similar to the other drugs. I guess the question you raise is, should it be higher than some of the other drugs? And you're right. I guess maybe 10 years ago, that's what I would have guessed too, but it hasn't turned out that way. And maybe that speaks to the way the drug is dosed, or its pharmacodynamic activity around its dosing regimen. I don't know, but certainly we see. Well, we're going to talk about COVID later, so I'll let Xavier go.
Yeah, we had love to go.
The one thing I'll say about Shingrix too is that Len, your group did a really nice evaluation of Shingrix, showing that there is a small risk of disease reactivation, particularly in RA, and particularly people who have poorly controlled disease activity at the time of vaccination. And I think that's a really important paper, and I wanted to highlight that. And I'll also say that we're just starting a study now in IBD and RA, looking at patients on JAKs and TNF blockers who receive Shingrix, primarily to better understand, to hopefully optimize how to give it in this setting. I suspect, based on our experience with other vaccines, that the immune response might be diminished by some of these DMARDs. And so we're certainly going to try to look at that and see if we can find out the best way to maximize immune responsiveness with that vaccine.
Great. Hey, I think we need to move along. So let us segue here to Professor Marriott. I partially introduced him. I think of Xavier as a clinical immunologist who does rheumatology because he is interested in such broad questions across the spectrum of immunologic disease. He's involved in numerous trials and databases, and has really helped us understand the intersection of targeted therapy and a lot of conditions, particularly infections. We could take the next 2 days and talk about COVID-19 and rheumatology, but you got about 15 minutes here, Xavier, to present and discuss. So go ahead.
Thank you so much, Len. Thank you, Kevin. Yes, of course, this 2021 year was dominated by COVID. And of course, COVID had a lot of impact on our patients with RMDs. So I selected some of the most important papers during this year. The first one is, what is the risk of severe COVID in our patients with rheumatoid arthritis treated with different drugs? And for answering this question, there was a very important collaboration between Europe and the US and all over the world, with a consortium called Global Rheumatology Alliance. So this Global Rheumatology Alliance proposed to physicians to include in a registry every patient with RMD having COVID, and to follow the severity of the COVID. And the definition of severity was a death or ICU admission of the patient. And so there was a first paper on all the rheumatic disease, and the second one restricted to rheumatoid arthritis. And in this paper, the number of patients was more than 3,000. And it could be possible to decipher what drugs could be associated with a worst outcome, which is either ICU admission or death. And you can see, to make the story short, that two drugs were associated with the worst outcome. The first one is rituximab with an odds ratio of 4, and the second one is JAK inhibitors. As you can see, JAK inhibitors multiplied by 2 the risk of a severe COVID. Interestingly, there was no effect of anti-TNF, anti-IL-6, or abatacept. So that's very important paper because, of course, it emphasizes the fact that the patient treated with rituximab, JAK inhibitors, and also steroids, in the other paper, steroids were found to be associated with more severe COVID, are prone to develop more severe COVID and have to be protected. Next slide. The second paper, important, is the effect of the drug we give every day to our patients with rheumatoid arthritis or with autoimmune disease in severe COVID. And really, you know that in severe COVID, it is pulmonary insufficiency, and it is linked to an hyperinflammation status. And so it was completely logical to use anti-inflammatory drugs in the treatment of COVID. And during this year, we had numbers of trials with different types of immunomodulators for treating severe COVID. You do know that the first drug, which is used everywhere in the world, is dexamethasone, which is a standard of care of treatment of patients with severe COVID. And in this year, it was demonstrated that anti-IL-6 inhibitors were also efficient in the treatment of severe COVID. You can see this meta-analysis published in the JAMA of 27 clinical trials, and it was clearly demonstrated that the risk of death was decreased by 14%. It's not spectacular. If you focus on tocilizumab only, it is 17%, and the risk of admission to ICU or death was decreased by 25 to 30%. So now there is some studies which try to compare combination of dexamethasone plus tocilizumab versus dexamethasone alone. And again, there is a trend of better outcome with the combination of dexamethasone and tocilizumab. Next slide. The third paper I selected is the effect of another rheumatic drug on severe COVID, which is baricitinib. And you can see in this study published in the New England, which was a phase 3 study in patients with severe COVID, they were randomized to receive either baricitinib or placebo. And the primary endpoint was progression to high flow, invasive ventilation, or death. And you can see that there is a trend to a decrease of progression to this outcome in patients with BARI. And if you look at mortality, there was a statistically decreased risk of death in the patient treated with baricitinib. So today, anti-IL-6 and JAK inhibitors, because we have the same result with TOFA, are considered to be used in patients with severe COVID if the patient does not respond to dexamethasone. And regarding these two results, and especially JAK inhibitors, we could imagine a discrepancy between the fact that patients treated with JAK inhibitors or with steroids at higher risk of severe COVID, but conversely, if you have severe COVID, this drug might be efficient. But it's not contradictory. In fact, in the first case, the fact to be treated by this drug may decrease the response, immune response to the virus. And in the patients with severe COVID, the treatment of hyperinflammation with this drug may have benefit effect. Next slide. So the last issue regarding our patients with RMD and COVID is the efficacy and safety of vaccination. We had this paper published in Annals of Internal Medicine showing that overall, the efficacy of vaccination is not bad in our patients with chronic inflammatory disease as you can see, up to 90% versus 100% in controls. And the patients having a lower level of anti-spike antibody after vaccination were the patients treated with steroids or with rituximab or anti-B cell therapy. Next slide. So this was confirmed by numbers of studies, the fact that rituximab impaired the humoral response to the vaccination. And for example, we have recently published with Mass Group a study on 30 patients treated with rituximab and having been vaccinated. As you can see here on the slide, the efficacy of humoral response was only 29% in the patient treated with rituximab. And if you consider the patients who received rituximab in the past 6 months, none of these patients got a humoral response to the vaccine. But the good news in this study is that if you look at the cellular response, which is at least as much important than the humoral response when you vaccinate someone, and we may discuss that with Len and Kevin in the discussion, the functional T-cell response was conserved in the patient treated with rituximab. And there was even a tendency to be a little higher than in the control, and it was preserved even in the patient without any humoral response. And the last slide will assess now the safety of the vaccine. It is a key issue because our patients with autoimmune disease sometimes are reluctant to be vaccinated because they're afraid of a flare of the underlying disease or of other autoimmune disease or side effects. So we designed with Yular and Pedro Machado a registry all over the different countries, and US participated to this study. 30 countries participated, and we registered 5,000 patients with rheumatic disease who have been vaccinated, and they were registered at a consultation made after the vaccine with the rheumatologist. And we could register the safety of the vaccine. What are the results of this registry? We had 5,000 patients with inflammatory immune disease, and we also had 400 patients with mechanical rheumatic disease, which could be considered as a control group. Firstly, we found a breakthrough infection in 1% of the patients. It is very well known now. It was at the time before Omicron, and so a good protection of the vaccine regarding breakthrough infection. The flares of the rheumatic disease, or the inflammatory rheumatic disease, occur in only 4.5% of the cases, and we had only 0.6% of severe flares. We have some severe flares, but the frequency was 0.6%. And lastly, if we look at the adverse event, it was exactly the same, 37% in the inflammatory patients and non-inflammatory patients. And interestingly, it is exactly the same in the phase 3 studies of the vaccine in the general population. But if we consider SAE, it was very rare, 0.4% in our patients with inflammatory disease, exactly the same incidence in the phase 3 study in the placebo group in the studies conducted in general population. So probably no relation with the vaccine. So these data are reassuring for our patients, and in my country at least, it has helped us to convince the reluctant patients with autoimmune disease to be vaccinated. Thank you very much, and we'd be happy to discuss.
Excellent. Well, Xavier, you picked a very interesting and impactful group of papers, and your recent paper is a really a quality contribution to understanding this literature. So let's kind of back this up a little bit. So we understand COVID-19 as this dynamic disease where the patient encounters the virus, triggers innate immunity, generally it goes on to trigger an adaptive immune response, and within a couple of weeks, everything is starting to subside, except for in those vulnerable patients who go on to a hyperinflammatory phase. And so you talked about IL-6 as inhibition as having an effect in this phase 3 hyperinflammatory. We know dexamethasone is a standard of care, and now we see baricitinib. On the other hand, you showed the first slide showing that baricitinib and JAK inhibitors are a risk, and I'm sure that we'll interpret that as vulnerability. I'm going to ask you, to give us your thoughts on the nature of this. And then secondly, the hard question is that when your patient who is on baricitinib and calls you and says, Dr. Marriott, I've just been diagnosed of having COVID. What should I do?
Thank you, Glenn, for this very interesting and difficult question. For the first one, as I said, it is just an apparent paradox because, as you said, COVID evolves in two completely different phases. The first phase is the virus is entering into the body and you have to get an immune response against the virus. And if you are treated with JAK inhibitors or with high-dose steroids, this immune response will be probably not high enough for eliminating the virus. In the very rare phase of hyperinflammation occurring 7 to 10 days after infection, the story is completely different. The severity of the disease is mediated by the hyperinflammation phase. And in this situation, you have to use anti-inflammatory drugs. So finally, if you think at the pathophysiology of the disease, you may understand this apparent discrepancy. Your second question is more difficult. I think my position now is to do like any infection in patient treated with targeted DMARD. So if it is a benign infection, and if the COVID seems completely benign, I did not ask the patient to stop baricitinib or any other targeted drug. If the patients get fever more than 38.5, I do, in all cases, and I ask the patient to stop the drug, the time of the high fever and the time of finally, the time where the infection seems to be severe. But it is something, as you say, which is not easy to understand, to answer, but it is in my practice, it is what I do.
I'm going to, before I turn to Kevin, I would say we're on the same page in dealing with this. And I think it's a testimony that is quite sad, actually, that 2 years into this, we are virtually using no biomarkers to guide these therapies. These are bedside decisions being made 98% of the time. We see a little bit of this SUPAR, anti-IL-1 kind of thing coming down, but most of our decisions right now across intensive care units are clinical. Kevin?
Yeah, it's interesting. I mean, I thought the SUPAR anakinra trial was really cool. I guess that's a good word to use. So, I mean, there is some attempts to look at biomarkers. I know Xavier's group, they were looking at biomarkers in driving, the use of tocilizumab in one of their trials. And I guess I'd just say in some ways, most people who get really sick and need these type of immunosuppressive therapies, their biomarkers aren't really specific, right? All the things we'd expect to be going through the roof are going through the roof, and the things falling are the ones we'd expect to be falling. And I don't know that, even when I was involved in some of those attempts early with some of the IL-6 drugs, particularly, and then the monoclonal antibodies to really sort out, if you could find subgroups of people that were responding better than others based on certain biomarkers. And, nothing really panned out. And I agree with you. It's too bad. I would have guessed that probably we would have more directed therapy at this point. But, maybe it's just, speaks to what we all learned going through med schools. You treat your patient, you listen to their lungs, they don't sound good. You see how they look, and then you treat them in a certain way. And kind of that's how we've done it, right? People get put in these clinical buckets based on their hypoxia and their ventilatory requirements. And then, they either respond to something or don't. And if they don't, then they get their dexamethasone, and then they get their berry or their toss on top of that. And so it's really interesting. So
I agree. I'm just saying that I'm kind of frustrated here. I'm expecting, 2022. I mean, give me that machine learning, artificial intelligence.
Yeah.
I think it's one of those topics that I think, more people are living off of it than dying from it. And we just haven't seen it. But at any rate, all good points.
Yeah, maybe Kevin, just regarding biomarkers, yes. In our study with tocilizumab in severe COVID, we have found that people with more than 150 milligram per liter of CRP were better responder to other people. So a very simple biomarker. Regarding anakinra and supa, I'm not so convinced. This study is a nice study. It is positive, but maybe you know that there are 3 other RCT with anakinra, which are completely negative. So I was very surprised to learn that there was an approval from FDA and from EMA of anakinra for treating severe COVID. I'm not so sure that it is a drug which is very well adapted to that.
Yeah, no, I'd agree. Although that paper tries to make the case that, using the biomarker, selects the right patients. So it'd be nice to see that
SUPARs.
Yeah. I've been checking my SUPAR every day, and so far fine.
All right, let's turn to rituximab, and I want to just ask before we move on here. It's a beautiful paper, Xavier, and your T cell assays are highly analytic and, as you say, robust, if not, on the upper side. So, others, as you're well aware, have looked at this, particularly in the MS literature, and have suggested, at least, the group from Penn, E. John Wary and those guys, have suggested that while there is robust T cell activity, that network analysis suggests it's dysregulated. So I guess that the actual answer is we need bigger cohorts of data of rituximab COVID patients to decide if their T cells are good, they should be doing great. And that's not what we're seeing.
Yes, Len, but it is what we saw before the era of vaccination. So I agree with you. We have to be very cautious and to wait now for new clinical data to see if this T cell response is protective or not. Yeah.
Okay. All right.
Yeah.
We got to move on. We're getting our cue over here. So I'm going to talk a little bit about a few studies here that have, I think, deserved some highlight. This first study is upadacitinib in patients with psoriatic arthritis and who have been inadequately responded to biologics. This is the SELECT PSA2 study. Psoriatic arthritis has just been so heavily studied in the past 3 to 5 years. We have so many drugs. It's a gift of riches, I guess, literally and figuratively. And so these data speak for themselves. And what you're looking right here is ACR20 responses. And as with other JAK inhibitors in this, challenging patient population, the response is brisk and it is high. These are up to 70%. Secondly, on the crossover, you can see that patients catch up. So it's a real response. And I don't think there's any big surprises here to anybody. When we dug deeper into these data, minimal disease activity was achieved in about 40%. And the skin responses of the 75, 90s, and 100 were quite respectable. I think they're like 60, 50, 30, 40, something like that. Not in the league of IL-23s, but this is a very potent drug, and this class will be coming, it is arrived in this disease. And when we get to talking about safety issues at the end, I think it'll be particularly interesting. So this second abstract we selected is interesting and important in a different kind of way. You know, we have, as I said, we have all these drugs. We have, you know, we have TNF inhibitors, we have IL-17 inhibitors, we have IL-23 inhibitors, we have JAK inhibitors, all to treat diseases within this. And I'll give a shout out to a paper that we're not covering, but it was a narrative review in the New England Journal on cytokine hubs in these diseases by Georg Schett and Ian McInnes. Fabulous paper from mid-year, which talks about, you know, there's a lot of crossover between these drugs and this disease. We have virtually, you know, very few, if any, head-to-head trials with biologics in any diseases. And so we're always comparing them. You know, how does TNF compare to JAKs, or how does IL-17 compare to IL-23? Or we want to know all this stuff. Well, the way that we compare these things in the absence of head-to-head trials is generally through meta-analysis of these trials, and we try to make them fit, and we try to compare the populations, and you know, but you can only look at one versus the other. So this is a statistical technique that I'm really not authoritative on, but it's a network meta-analysis. And this is actually designed to take a meta-analytic perspective, but it can look at multiple interventions against each other. And so, you know, there's a lot of numbers here that come out of that type of analysis, knowing that these are not, you know, totally comparable studies, but they're supposed to adjust for this. And, you know, the results are actually, you know, a little bit kind of surprising to me. So when you compared these drugs used in the way that we use them, secukinumab, ixekizumab, tofacitinib, in particular, with an additional comparator, the ACR20 response was bested by secukinumab. And, you know, this met some type of statistical significance in this analysis. And it was followed by ixekizumab and tofacitinib. So tofacitinib was actually, you know, kind of pulling up the bottom of this. Now, I'll be interested in people's take on this type of analysis. As I said, I don't feel that I'm an expert in this. And does it have face validity? I'm not totally sure, but you know, when you give this drug in high doses and give it frequently, all of these drugs work. I consider them all relatively on the same plane clinically, but with different influences as to why you would use it, from comorbidities and beyond. So this is more of a puzzle abstract. So the last one is TOFA and AS. So spondyloarthritis is a disease that's coming on strong now, kind of in the wake of psoriatic arthritis. And, you know, for a long time, you know, we had TNF inhibitors. And now we have both ankylosing spondylitis, we have non-radiographic spondyloarthritis, and we have a new bevy of drugs, the IL-17s, which are highly effective. And we've been waiting to see JAK inhibitors. And this is tofacitinib trial, patients who were NSAID-IR. This was at 5 milligrams BID. You know, this is generally a young population of people, so it's not burdened by a lot of cardiovascular morbidity. These responses were impressive. You know, very quick action. You can see by the ASAS 20 and 40, the levels are very responsive. And, you know, these patients have other comorbidities that make a JAK inhibitor, which has broad MOA, of interest. So, at any rate, those are the abstracts that I picked. The last one, I'm really going to hold on this for time purposes. This was the EULAR points to consider on JAK inhibitors. It basically said shared decision making and be consistent with international and national recommendations. So This is a moving target, and Kevin's going to take a deeper dive into it. So let's open this up for discussion. Any of you guys have a good feel on these network meta-analysis? Do you feel that this is lies, and damn statistics, or is this the way to go?
Meta-analysis, schmeta-analysis, Len. That's what my professor taught me in epi class long ago. I mean, obviously I'm kind of joking around, but
yeah, right.
But you do have to take some of it with a grain of salt, and there's assumptions made, and everyone's doing the best they can in those type of analyses, but there are limitations. So
yeah. Second point here, I just make before we can move on from this psoriatic arthritis. It went from a disease where we had virtually nothing to virtually everything, and it's as they say, a wealth of riches. Adding JAK inhibitors to this, Xavier, do you think this is going to have a big impact on how you manage this disease?
Sure. It is as you demonstrated, the drug, this type of drug work very well. Now, and it will be an introduction to the next part of our symposium. The key issue is the safety, of course.
Yes, and with that point here, because this is really a highlight of 2021, and it is the intersection of a drug class meets regulatory scrutiny and some new data. And Kevin, you've been studying this as much as anybody anywhere. So take us through this.
Sure. Thanks, you guys. It's the highlight of 2021, but it feels like it's been going on forever. For like five years or longer. I don't know. So, we're just going to focus on two of the highlights from the oral surveillance paper, which was just published in New England Journal last week. In terms of infection, I don't think we really learned anything new. It was very consistent with what we knew already, but there are some things here to talk about, particularly with malignancies and cardiovascular events. So as most of you know, this was a post-marketing FDA mandated safety study, primarily brought forward because of the safety signal seen at the higher dose, the 10 milligram BID dose during the development program of tofacitinib for RA. And this was powered as a randomized prospective clinical trial that was open label. Patients were randomized. It wasn't just any patients. It was really those at high risk for cardiovascular disease and probably at higher risk for malignancy based on their age. So these were patients greater than 50 with RA, and they had to have at least one or more cardiovascular risk factor. And they were randomized either to etanercept or adalimumab, depending on where they were in the world. And that was the TNFI reference group, or they were randomized to either the higher or lower dose tofa group. So of course, the 5 milligram BID tofa group, that is the dose that was approved for use in RA. And then there was the higher dose, the 10 milligram BID dose, where there was some increased efficacy seen in the development program, but there were some concerns about dose-dependent safety signals, which again was the reason for this trial. So this was an event-driven trial. There were non-inferiority criteria around malignancy and around cardiovascular outcomes, so MACE outcomes. If the confidence interval, the upper bounds were greater than 1.8, then the trial was, supposed to stop if enough events had been accrued. So once it hit the right number of events for both malignancy and cardiovascular outcomes, the trial stopped. And, the way it was powered again was to see if tofacitinib was non-inferior to TNF. Let me see if I can move this slide to the next one. So with regards to malignancy, I thought this was a bit surprising. There have been malignancy signals with this and other compounds that have come and go over time. But this was really the first real solid evidence that maybe tofacitinib or JAK inhibitors are associated with malignancy beyond NMSC, for example. So these are malignancy outcomes that exclude NMSC. We see a hazard ratio of about 1.47 or 1.48 for either dose group. And this was statistically significantly higher than what was seen for TNF blockers. I will say that what makes a lot of this data somewhat muddy is that halfway through this trial, given the signals around VTE primarily and mortality that was increased with the 10 milligram BID group in TOFA, that everyone on that group was then moved over to the 5 milligram group. So this is really kind of at the end of the trial, a blending of the 5 and 10 milligram group, as again, most of those people on 10 had been moved down to 5 in the last several years. So that may explain why the hazard ratios look quite similar for the two groups, because they're kind of blended together. Suffice it to say, this was driven by very specific subgroups, primarily older individuals who smoked. And a lot of this was lung cancer. But there were several other cancers that were disproportionately more prevalent in the TOFA group. I'll say melanoma was more prevalent in the TNFI group, although that did not reach statistical significance. Suffice it to say, there does seem to be a signal relative to TNF blockers, at least in some of these subgroups of patients, older individuals and primarily people who smoked. And it wasn't actually seen in all regions of the study. I believe this was primarily driven by the North American part of this cohort in terms of this malignancy signal. In terms of MACE events, and actually I'm just going to go back because it looks like my MACE events are here. It's a small table on top. You do see that, oh, there we go, thank you. The adjusted hazard ratios here in the fourth column, or fourth row, I should say. There is a dose dependent increase as compared to TNF blockers. So the TOFA 5, the approved dose, the value was 1.24. For TOFA 10, it was 1.43. Now, again, you see wide confidence intervals here crossing 1. So these were not statistically significantly worse than TNFIs. They rather failed to meet non-inferiority. So, they were statistically deemed not to be non-inferior. So I guess you could say they're inferior. That's what we're seeing here. So, I would just say that maybe this is surprising a bit, but not necessarily based on the data we saw in the developmental program, particularly with the higher dose of TOFA. There was a nice real world study called the STAR study. It was just published about a week ago. Also, I think in ARD or arthritis and rheumatism, I can't remember, but it was a real world analysis of population-based data in the US where they did not see an increased risk for MACE events in people starting TOFA as compared to TNF blockers. But when they looked at people with the entry criteria similar to this trial, i.e. those over 50 who also had cardiovascular risk factors, they actually saw the same exact hazard ratio for TOFA 5 of 1.24. So maybe there is a slight risk here relative to TNF blockers. But again, it's relative to TNF blockers, which we already know from a number of studies are protective against cardiovascular events. So I think it's important to keep that in mind. So in summary, the FDA and the EMA both issued warnings about the use of tofacitinib in patients who are over 50 and have risk factors for malignancy or cardiovascular events. FDA was a little bit different than EMA. They extrapolated their findings to all JAK inhibitors, just kind of thinking that perhaps all JAK inhibitors carry the same relative risks as tofacitinib. I think that's an open question and one that I guess we could debate, but certainly one that needs study. EMA did not do that. EMA just made their warnings tofacitinib specific. So there you have it. The Europeans and the North Americans handled it differently, just once again. The last slide here just highlights some of the things I already told you. We didn't get into the VTE and PE issue. I will just say that there was a dose dependent increase noted in VTE with 10 milligram TOFA being higher than 5 milligram TOFA being higher than TNF blockers, although there was no statistical significant difference between the 5 milligram dose and the TNF blocker dose. Although again, there was a numeric increase. So I think the VTE question is still a bit of an open question, but the fact that there was a statistically elevated risk at the 10 milligram dose makes me just think, if you push this or probably all JAK inhibitors high enough, you're going to get enough pan-JAK or enough JAK2 or off-target effects that you're probably going to find an increased risk in at least some subgroups of patients. So I'll leave it at that. And we could probably discuss this. And then again, this is just the end of the FDA warning here, which I've already summarized. So Len, Xavier, what do you guys think?
Yes, thank you, Kevin. Yes, of course, it is an important study, and it emphasizes the fact that it's very good when the agencies ask to the companies to do long-term study, head-to-head studies for really assessing long-term safety of drugs. I think that the key issue now is, as you said, Kevin, is it linked to TOFA or is it a class effect? And what could be the mechanism of that? Regarding cardiovascular risk, it is maybe just because TNF are protective and JAK inhibitors are not. But regarding the cancer risk, it is more problematic to see and to understand the mechanism. And I have a question to you, Kevin, who are an expert in zoster and infectious disease. Do you think that the inhibition of function of NK cells could play a role? And do you think it could be a parallelism between the risk of zoster and the maybe small increased risk of cancer because of NK inhibition?
Yeah, well, it's funny. I was going to ask you the question because you guys did that just real elegant work looking at the functionality of NK cells in the influence of TOFA. I mean, I think I was involved initially looking at, levels of NK cells, right? We all noticed that the actual levels went down when patients started TOFA, and, speculated that might have something to do with zoster. And then you guys did the experience showing that not just the levels are down, but the NK cells don't work as well. So, I think, in terms of zoster, there's probably multiple ways JAK inhibitors cause an increased risk of zoster, and that would be one potential mechanism. Others include just simply dumbing down interferon gamma signaling. Others include, decreasing CD4 responses and cell-mediated immunity, right? So all those things could potentially play into the body's ability to do immunosurveillance for cancer. I guess, I'll turn it back to you. I mean, you guys looked at the NK cells in, I think the cell line you used was some sort of lymphoproliferative cell line, and you found that they didn't control those cells as well, correct?
Yeah, correct. Yes. In vitro, there could be some impairment of control of some cancer cell lines. And of course, now it will be very interesting to compare different JAK inhibitors regarding this type of inhibition.
Yeah, no one's really done that. Not all JAK inhibitors, you see a decline of NK cells. And then again, there's the functional question. I mean, I guess I've always thought that none of those compounds would cause cancer. I think in patients who have existing cancers, it might make it a little easier to discover them because clinically, because your immune system's not doing as robust a job to maybe control their growth or to find them. So these are theories, of course, and I guess my thought is there could be differential risk between compounds. And I'm not exactly sure there's risk. I guess kind of this oral surveillance data speaks to the statement I just made. I mean, the people who probably had cancer in that trial were people who already had probably small incipient cancers. They're really old, they're smokers, they probably had some lung nodule that you couldn't see on a CT scan necessarily, or they don't have a CT scan, and they get put on this drug and they're more likely to progress. I mean, those are my thoughts, but I don't know. It certainly deserves further study.
Sure.
What do you think about the DVT issue and VTE? How are you guys handling that in Europe?
Yeah, I think DVT and VTE, there is clearly a class effect in oral surveillance, which is not the case, for example, for cancer or even for MACE. And I think it is really linked to high dose of JAK inhibitors. So maybe we can deal with that when the 10 milligram has been abandoned. And it's a problem, for example, for colleagues from gastroenterology, because we do know that 10 milligram works much better than 5 in IBD, for example. So really, in this side effect, there is a dose effect.
Yeah. You know,
I
I just think the VTE story is so interesting, right? I mean, I was involved in the Berry program. I was on the DSMB years ago at the start, and we saw that imbalance early, but you know, the overall rate of VTE in that program it's published, and it's pretty consistent with what we see in RA in general, right? About 0.5 per 100 patient years. So, you know, all of this came about based on a 6-0 imbalance between, you know, Berry and placebo and what the first 12 or 24 weeks, I don't remember the time point, but, you know, I think it's still an open question personally, whether Berry actually causes a VTE, but this data, of course, makes us think it's more likely that maybe there is some risk. And I guess if I had to speculate, and I am speculating, that, you know, tofa at 10 probably has a lot more JAK2 inhibition than tofa at 5, or we know it should be. And it seems like maybe the JAK2 inhibitory pathway, there's something there that is explanatory towards an increased risk of VTE, but I'm not smart enough to figure out what the mechanism is. And I don't know if anyone is. Actually, you're smart enough.
No.
What do you think?
I don't know, but your hypothesis is interesting because it has been shown with Berry, firstly, which is more JAK2 than tofa. And maybe the inhibition of JAK2 could be important regarding this adverse effect.
Yeah.
And maybe one other important message from oral surveillance is that TNF inhibitors are really fantastic drugs now regarding the compromise between efficacy and safety. 20 years after they have been launched, really we have now a fantastic amount of data regarding their efficacy and their safety. And I remember in 2006, when there was this meta-analysis in the JAMA showing that TNF inhibitors could increase the risk of cancer. Everyone was really absolutely very concerned about that. And finally, all the other studies did not confirm this increased risk of cancer. So we have to be cautious. We have to wait for time. But really what we can say now, we do know that TNF inhibitors can decrease the cardiovascular risk. We are really very well reassured regarding the risk of cancer, regarding the risk of infection, which is really manageable. So it is also something which is interesting, maybe to take from this study, that maybe we need time for really knowing the complete safety of a drug.
Yeah, and I always stress that it's all relative, right? I mean, what was the reference group? It was TNF blockers. Even the COVID data you showed, right? You know, it was against TNF blockers, which are probably protective against COVID. So, you know, I would think with cardiovascular events, if you studied tofa or JAK inhibitor versus you know, methotrexate or something, you might see that JAK inhibitors are protective. I don't know, but that would be a hypothesis. But you know, they weren't studied against other drugs there. They were studied against TNF blockers that are probably protective. So it's all relative, and it just raises the bar that the question. The idea that we really need to do more head-to-head comparisons. We don't, particularly JAK versus JAK, because I mean, with FDA kind of lumping them all together, you know, I obviously people need to study them head-to-head to see if that's really appropriate. I'm not sure it is, particularly with some events. Other events like zoster, maybe it is, but some of these other events, I'm not sure. So yeah, I don't know. Maybe we should turn it over to the audience to see if they have any questions. I think they have the ability to go ahead and either put them in the chat or raise your hand. I don't I don't know. CSF people, how are they supposed to do it?
They can use their Q&A function, which they'll find at the bottom of the screen.
Great. So if anyone has any questions or comments, please go ahead and tap those in. And then I assume they'll be relayed to us here. And while people are thinking about that, I guess my only other comment would be, you know, I think JAK inhibitors are safe in most patients, and I think oral surveillance actually speaks to that. If you look at the people who are in that trial, there's certainly subgroups of patients that you probably want to steer JAKs away from, but probably younger people. Of course, younger people weren't in that analysis, but based on all the other data we have, probably quite safe. Most younger people, particularly at the 5 milligram dose. I think some of my colleagues here are doing things, handling it differently, but I know some are not using them in certain subgroups of patients, particularly people with history of VTE who are not anticoagulated. Anyway, we can think about these individual subgroups, but I think by and large, there's still going to be a good option for a lot of patients. And again, this study, you just got to remember, it speaks to a very specific choice. Your choice is TNF blockers or JAKs. And, so I guess as a practicing rheumatologist, it's really that patient walking in where you're having to make a choice as to what to start. And obviously TNF blockers are tried and true at this point. But I don't know, do you think it's changing practice, Xavier, for you guys?
I think, as you said, Kevin, the inclusion criteria in this study were very specific, more than 50 and 1 cardiovascular risk. So again, as you said, in young people, I think we can say that JAK inhibitors are safe drugs. And it did not change my practice in young people, in young patients. In patients older and with risk factors, maybe it could influence the choice when you have the choice between different drugs. And clearly, our obsession in these patients is to improve them, but not to induce other type of diseases. So I think we have to wait now and to understand more about the mechanism. But at least surely high dose of TOFA should be avoided in our patients. That's a clear conclusion of that. And as I said, it's a problem for gastroenterologists, but not for us, because in our diseases, 5 or 10 is roughly the same effect. And I think I wait now with impatience the studies with other JAK inhibitors. I do know that FDA has asked to Lilly to conduct the same study with Barry, but we will have maybe the results only in 2 or 3 years. I don't know.
Yeah.
I don't know if you have more information about that.
Maybe 10 years. I don't know. I'm not sure when that's going to finish up. But yeah, it's going to be several years, I think, at least. So we'll have to see. I guess I tended to agree with EMA. I would have made the warnings more TOFA specific because that's where the data was. So, but maybe the FDA's better safe than sorry approach is right. I guess we'll find out in 3 or 4 years when we have more data. Hey, one question in the chat just about, and I think you already answered it on the European side, but are you considering giving Shingrix to patient before they start immunosuppression? I would just answer yes. I mean, it's always better if you can give that vaccine and others before you start, if you can. Obviously, it depends on disease activity in the patient. And sometimes you're boxed in as a rheumatologist. Someone's really hot from a disease activity standpoint. It might be better to go ahead and try to get their disease under control before you immunize them. They'll probably have a better response. And that's true of most vaccines. So my answer would be yes, in general, try to give it before they start the immunosuppression, but also try to give it when patients are at the lowest disease activity possible. And I think lens data, as I mentioned, showed that you can flare with Shingrix, particularly if you're not in good disease control at the time of vaccination. So, I think, I certainly with the COVID vaccine and all the DMARDs, we're seeing data trickle out. We're collecting that data with Shingrix. I mean, I suspect some of the DMARDs downregulate or diminish that vaccine response and might ultimately make it less effective. I think that's very likely. So I think we have to figure out how best to give Shingrix, just like we do COVID-19 vaccines and other vaccines in terms of, targets and timings, which vaccines to use and when to use them in relation to DMARDs. So Xavier, do you have anything else to add to that before we close up?
No, I think we had very interesting new papers in 2021. Still a lot of questions not completely solved, but that's life, and that's why rheumatology is so exciting.
That's right. It's a good time. It's a good time to be here. So,
Yeah.
well, I think I can just summarize for us. I know Len has left the building. He's racing the snowstorm to the airport to get out to Arizona to join his wife. So, as usual, it's fun to present with him and use Xavier. I think we highlighted some nice articles about the utility of various biologics, including JAK inhibitors, in the setting of RA, and particularly the safety of DMARDs and the use of JAK inhibitors and IL-6 blockers in the treatment of COVID-19. I guess that'd be my summary. I look forward to 2022. I look forward to fewer COVID-19 papers. Xavier, what do you think?
Yeah. And maybe the combination of biologics in severe COVID and maybe to be completely sure of the protection of our patient with the vaccine, whatever the drug they receive, that's the challenge for 2022.
Yeah, I agree. I think that the questions in 2022 are going to be all about the length of vaccine protection, and when we should be giving new boosters, and then of course which boosters to be using. And I think those are really important questions. The other questions too, and as you just mentioned, I mean, the active trials in the U.S. will be reading out on the efficacy and safety of Tnf blockers in treating COVID, abatacept in treating COVID. So those will be really interesting analyses to look at. I suspect both those compounds have benefit in certain COVID patients who, at least hit a certain clinical stage of disease. So we'll just have to see, but that's what's to come, and I look forward to hopefully traveling again and maybe seeing you guys in person.
Okay. Thank you to